Welcome to Clinical Tools Library, evidence-based scales and questionnaires designed to support healthcare professionals in practice. The Frailty phenotype assesses physical frailty in older adults by evaluating 5 specific criteria: unintentional weight loss, self-reported exhaustion, weakness measured by grip strength, slow walking speed, and low physical activity. Its main purpose is to identify individuals at increased risk for adverse health outcomes such as falls, hospitalization, disability, and mortality. This assessment helps clinicians stratify patient vulnerability and guide appropriate interventions to prevent functional decline and improve health outcomes. The Frailty phenotype is indicated primarily for older adults, typically those aged 65 years and above, who are at risk of functional decline. It is most useful in geriatric clinical settings, where the identification of frailty can guide interventions to prevent adverse outcomes such as falls, hospitalization, and mortality. The phenotype assesses specific physical criteria, including unintentional weight loss, weakness, exhaustion, slow walking speed, and low physical activity. This tool aids clinicians in stratifying frailty status to tailor management plans, optimize resource allocation, and improve patient outcomes in community-dwelling elderly populations and those undergoing elective surgeries. The Frailty phenotype consists of 5 items assessing physical frailty domains. The first item measures unintentional weight loss exceeding 10 pounds in the past year using a yes or no response format. The second item evaluates self-reported exhaustion through 2 questions derived from the Center for Epidemiologic Studies Depression Scale, with frequency responses such as 3 or more days per week, indicating a positive criterion. The third item assesses grip strength via dynamometer measurements adjusted for gender and body mass index. Values below the 25th percentile correspond to frailty. The fourth item examines walking speed over a 15-foot course, with time recorded in seconds. Thresholds for slow gait are based on gender and height-specific cutoffs at the lowest 25th percentile. The fifth item records self-reported physical activity using the Minnesota Leisure Time Activity Questionnaire, calculating kilocalories expended per week. Values in the lowest 20th percentile indicate frailty. A cumulative score ranging from 0 to 5 is calculated by summing the number of positive criteria. Scores of 0 indicate robustness, 1 or 2 signify a pre-frail state, and 3 or more denote frailty. This classification informs clinical risk stratification and guides subsequent management. The Frailty phenotype demonstrates a sensitivity ranging from 75 to 85% and a specificity between 70 and 80% in identifying frailty among older adults. Sensitivity refers to the test's ability to correctly identify individuals who are truly frail, minimizing false negatives. Specificity indicates the ability to correctly classify non-frail individuals, reducing false positives. For example, a sensitivity of 80% means that out of 100 frail patients, 80 will be correctly identified by the Frailty phenotype, while 20 might be missed. Similarly, a specificity of 75% implies that out of 100 non-frail individuals, 75 will be accurately recognized, and 25 may be incorrectly labeled as frail. These metrics are critical in clinical settings to balance accurate diagnosis and avoid misclassification. The Frailty phenotype test was first introduced in the early 2000s by Fried and colleagues as a clinical syndrome characterized by distinct physical criteria, including unintentional weight loss, self-reported exhaustion, weakness measured by grip strength, slow walking speed, and low physical activity. The initial validation study, conducted within the cardiovascular health study involving over 5,000 community-dwelling adults aged 65 years and older, demonstrated that individuals classified as frail exhibited significantly higher risks of adverse outcomes such as falls, hospitalization, disability, and mortality over a follow-up period of approximately 7 years. Subsequent research has corroborated these findings across diverse populations and settings, reinforcing the test's predictive validity. Construct validity has been supported by the association of the phenotype with biological markers of aging and inflammation, while test-retest reliability has shown consistent categorization in longitudinal assessments. Furthermore, the Frailty phenotype has been compared to other frailty instruments, frequently demonstrating superior prognostic performance for physical decline and clinical risk stratification, thus establishing a robust evidence base underpinning its clinical utility. Thank you for watching. For complete information and official PDF resources, visit clinicaltoolslibrary.com or check the link in the description below. And don't forget to like and subscribe for more clinical insights.